Okay, so like I say, we're moving right on, and so the next panel is obviously on monitoring and evaluation, those of you interested in those systems and those indicators and how they might, be able to be integrated in respective countries. And so we will have, it's generally called Partnerships and Lessons Learned. So our first presenter is Niamh Darcy from POPPHI. She's the M&E lead, and she comes from RTI International, and she'll be presenting Amstell M&E indicator, supportive supervision, and Amstell tracking in the HMIS. On to you.
Good morning, everybody. Let me just get started here. The first thing I did want to say was I really wanted to... Oh, closer to the microphone. Is that better? Yeah. Okay. The first thing I wanted to do was I wanted to thank all of our partner projects who have worked in a very collaborative manner with us as we've been developing M&E for active management of the third stage of labour, and been trying out different ways of collecting information and using that information and building M&E into their training. So I wanted to say a collective thank you to everybody for that. Okay, so just a little bit of background here. We started discussions in 2005 and 2006 with USAID, both with Mary Ellen Stanton and Lily Cack, to talk about trying to come up with a common standardised indicator that we could use for tracking active management of the third stage of labour. And then through several meetings and then through some follow-up, we kind of finalised in April of 2007, and we've been using that indicator across multiple projects. And you can see just at the bottom of the slide a kind of standardised indicator reference sheet. So basically the indicator was tracking the number of women in facilities, and at the time we were including home as well, although most of our work has really been based in facilities in terms of tracking this information. So just some general background on monitoring and evaluation. We were trying to come up with a common indicator that could be used at a national level, so that would encourage continued use of information for making decisions, basically tracking active management of the third stage of labour as well as postpartum hemorrhage incidents, so that providers and clients in facilities could see that the continued practice of active management reduced the incidence of PPH. And not just and that would be at the facility level as well as a national level. So when you have information, and we had information from our global surveys also, we can use that for advocacy at the district, regional and national level, working with HMIS staff in different departments and ministries of health. So to talk a little bit about capacity building, let me go on to the next slide here. One of the things as an M&E person that all M&E people like to do is integrate M&E right up front into your program design. So a critical component of the training was integrating the notion of tracking what people are doing and being able to look at what you're doing and see what the issues are, and then do some level of quality improvement so that you can continue to improve your practice, which will ultimately deliver better services to pregnant women and their newborns. So another area with that is supportive supervision, and that has been a mixture in different countries of project-based supportive supervision. In some countries we've been able to work to advocate to get supportive supervision for active management of the third stage of labour integrated into the reproductive health supervision tools. So there's a mix across different countries of where supportive supervision is. And to go back to the point I made earlier, it was really important to work with providers in facilities to understand the use of the practice of active management, the tracking of that, and how that can help them. And we worked in several countries where we were tracking both the practice of active management and the PPH incidents, so that information was up on the walls, immediately available to providers and clients. And that's an ongoing reinforcement of the importance of doing the practice, because if you see it being tracked on the wall and other people are doing it, and if you're moved into a facility from another part of the country, it reminds you of the critical how critical it is to keep practicing active management of the third stage of labour. So let's talk about some of the ways, and you've seen some of this from the Ghana, Mali and Bangladesh presentation earlier today. People were recording the data in different ways because it has to fit into what you're doing. What we were trying to avoid was introducing yet another parallel data collection system. What we really want to do is integrate with current data collection systems. So some countries added information to the back of the partograph, single markers, multiple markers for each of the three components. Some people put information into the patient record, either handwritten or with a stamp, which was ticked off for the different components. Some countries introduced a new column in the delivery register or log so that could be tracked. Some countries used the current treatment and follow-up field to put in that information, for example, in Mali, where people were writing in GATPA in that column, as well as the follow-up treatment needed. So let me just go to the next slide, and this is just a summary. It doesn't include every project because we've worked with a lot of different projects in different places, but just to give you an idea of which countries were doing what. So for the partograph with the pre-printed information on there, Mali, Ghana, DRC and Benin. Pakistan updated the partograph and the delivery log. In Bangladesh, they used a stamp, and that had originally, I believe, been used earlier in Niger, but that was used with a purple stamp to put the stamp into the patient's record and also into the delivery log. And Indonesia and Nicaragua are using a pre-printed partograph which showed all three components that providers were checking if they were doing those components. And of course, supportive supervision is really important here because, you don't want people marking things that they're not doing. You really need to have supervisors coming back in, looking at what's happening, looking at the information. This is what's happening with active management. This is what's happening with PPH incidents. Okay, so this is just a brief example. On the left-hand side, I have it in English. This is on the back of the Indonesian partograph, which shows what they added to track active management. The top right-hand side is the stamp translated into English for Bangladesh. And in the middle, I apologize, not a very good quality picture, but it's the use of GATPA, or writing in by hand GATPA on the delivery log. And then this is an example in Mali of where they were diagramming the PPH incidents and showing at this, for those 2 months it was 0, but they were doing that over a year, so you can see what's happening. And then just some general information about supportive supervision. Some of it, as I mentioned earlier, was project-based. Mali is project-based, but it's planned to be integrated with the Ministry of Health for 2010. And Senegal added to the National Health Reproductive Supervision Tools. And for some other countries, they're not going to introduce it into the supportive supervision tools until the indicator has been adopted. And then just some general information. Again, this is just a few sample countries. It's not everybody's country or partner projects we've been working with. But there's, as mentioned earlier, some countries have included Amstell already into their national health information system. Senegal, Nicaragua, and Honduras. Ukraine and Bangladesh right now are project-based. In Bangladesh, there's a strong commitment to move to include it once the practice is expanded to more districts, to getting to 60-70% of the districts. And Mali and DRC have plans to include that in 2010. So that's about everything I have to say right now. So I'm going to pass it over to Alfredo to bring the next person. Thank you.
Thanks very much, Niamh. And I know we are in a tight session. This one, we don't want to start eating into our lunch period now. But so appreciated all the, sticking to the time limit. So now I'll introduce Darren Trudeau, and he's a senior program manager for MNNCH and family planning and malaria for IntraHealth, and he will be telling us about assisting the Senegalese MOH to integrate Amstell into their health system.
Thank you. I'll try to make this as quick as possible so I don't eat into our lunch. I've been asked to represent our team here for the work to integrate Amstell into the MIS system in Senegal. The person who should be up here is Rodeo Diallo, our country representative, but she had to choose between either coming here or going to Cape Town on vacation, so she decided to go to Cape Town for some reason. Also on our team, Population Council is in charge of the M&E portion of our work. So to give you a little bit of background about integrating Amstell in Senegal, we actually started it off very early, and something that Niamh said just a moment ago about getting the M&E going at the very same time as the training is very important. So that's what we did in Senegal. So the team there had the foresight to start the process of integrating an Amstell indicator into the system at the very beginning. So it just gives you a little bit of timeline over 2 years. The first step was to start discussions with the DSR, which is the Department of Reproductive Health, and to get them to validate the new curriculum that we helped develop. Once that curriculum was validated, regional trainers were trained, so it was a TOT process. And on the M&E or on the integration side, the bilateral, which was funded by USAID, there was support provided to the DSR and to the national MIS system to organize a workshop to review and to harmonize a list of reproductive health indicators. So once that process had started, it was over the next year and a half, support was provided to review the tools, to update the tools, and also to on the training side to continue the training of providers on Amstell. And I might mention also that Amstell is integrated into essential newborn care in Senegal. Once the tools had been updated, we helped the Ministry of Health with the training of district and regional supervisors and midwives on how to use the new tools, and then we continue with the quarterly collection of data. This is just a quick snapshot of achievements. So in year 2, there were 509 providers trained, and there were approximately 75% of all births were attended by a qualified provider, and that was 47,946 women who received Amstell in facilities. And we estimate that there were approximately 3,581 cases of PPH prevented. By year 3, and we just entered into year 4, so by year 3, and this is only 40% of the data that has been received so far, there have been 40 or 83% of births attended by a qualified provider. And the number of facilities that we have covered in the 5 regions where we are working is 100%. So in total, we've estimated that there are approximately 6,316 estimated cases of PPH prevented. As you can see, this is our year 2 and year 3 data, and as you can see on the bottom, this is only data up to the second quarter of year 3. There's an increasing trend of the number of women receiving active management of third stage labor. That little dip that you see in there, there was somebody who mentioned before how providers they need to know the importance of having the data or collecting the data, and they have actually used the collection of data as a way to. They used it in a strike, so they had a provider strike, and what they did was they retained that data. They retained it from the ministry. So that's the little dip right there. And that's it. Thank you.
Okay, Darren has just illustrated one of the issues and problems that regular routine data collection faces. So anyways, that was interesting. So now for the third presentation, let me introduce to you Kathleen Hill, and she's a Senior Maternal Newborn Quality Improvement Advisor at the Healthcare Improvement Project. at USC, right?
Yes.
Okay, welcome.
Thank you very much, Fernando. Good morning to everyone, and many thanks for including us in this panel. And a very special thank you to POPPHI for all of their vision and leadership over the last years as an implementing partner. Their advocacy has been tremendously important. And I'd also like to especially thank Niamh Darcy, who has really provided very, very helpful leadership in terms of monitoring and evaluation. So I'm just going to jump right into the key message here that I'd like to share with you, which is that when monitoring is linked to continuous quality improvement, it becomes a very powerful strategy for implementing, scaling up, and sustaining Amstell. Particularly when, and I'm going to share some results from our programs, when facility providers and managers use monitored data in real time to continuously strengthen health systems to support Amstell. We have a picture here of one of our quality improvement teams from Niger that includes midwives as well as auxiliary midwives, matrones. And these are the core teams with whom we work to overcome the kinds of implementation obstacles that have been raised by several presenters in this room, ranging from lack of refrigeration to lack of easily accessible oxytocin at the immediate time of delivery. And in our work, we work closely with frontline teams, and we use data that they collect, that they record, that they're trained to collect as part of the initial training that they receive, as my fellow presenters have pointed out. And they use this data in real time to analyze the effects of their work. The other key message that I would like to give to you today is that when lessons learned are systematically shared among facilities and regions who are all working together to implement and scale up an intervention like Amstell, that this in itself can really accelerate scale up. And I'll be showing you some results from 3 of the 9 countries in which the Healthcare Improvement Project is currently implementing prevention of postpartum hemorrhage as part of what's called an improvement collaborative model, which is essentially where multiple teams work together in a very focused way to scale up a package of interventions. This first slide is from Ecuador, which is the country in which the Healthcare Improvement Project and its predecessor, the Quality Assurance Project, first began to implement prevention of postpartum hemorrhage work. And this run chart shows you over a span of 6 years from 2003 to 2009, successive waves of facilities joining what we call an improvement collaborative, where multiple sites are working together. And during an initial demonstration phase, as can be seen with the blue line, which was the initial 55 facilities, teams work on and use data that they're collecting to overcome barriers in their settings where they're working. And then those effective changes are shared with successive waves of teams who join the collaborative at later points in time. For the Ecuador case, the indicator that was monitored was percent of deliveries in which oxytocin was administered within 1 minute after birth. In our subsequent work, partly using the leadership of POPPHI, we have used an indicator that has included all 3 elements of Amstell. This is an example from Guatemala. All of the examples that I'm giving are from the facility level, so you've heard about an example of using Uniject and community level work. This, once again, the green line shows a demonstration phase of introducing Amstell in public maternities in 1 province, with a scale up to 70 maternities in 8 provinces approximately 1 year later, using lessons learned. This is a slide which many of you have seen from our partners in DC and from USAID, but we wanted to show it for those of you who may not be familiar with this work, that shows work that was begun in Niger to introduce Amstell as part of an integrated immediate postpartum essential newborn care prevention of postpartum package, to reinforce Indira's plea. And this shows that as Amstell was introduced, initially in 28 sites and then finally in 33 sites over a period of 2.5 years, as coverage of births reached near 100%, there was a concomitant decrease of over 60% of postpartum hemorrhage. This is taking records that facilities are maintaining at the local site with regular supervision. We did regular coaching and monitoring of data and building of capacity of teams, because so much of quality improvement depends on use of data. So a tremendous amount of our capacity building was invested in integrating technical competence with data collection and management. And by the end of the collaborative at the end of 2008, the number of births that was tracked was 31,000, which represents approximately almost a third of national facility births in Niger. This slide is to give you a sense of what we mean when we talk about overcoming implementation barriers, because it's easy to say, but we're hoping to try to illustrate for you. It comes down to such simple changes that need to occur in very resource-poor settings. So, for example, when we started working in Niger, there was no recording of Amstell in the national partogram. Oxytocin was there only as a measure for induction or augmentation of labor. And we, working with our teams, we were aware that this was going to be a great challenge for us, and one of our local Ministry of Health counterparts came up with the idea of a stamp, which then we very easily rolled out to all the sites who were together monitoring one common indicator. And then another example of very specific and really quite simple changes, but I would like to make the case that these are really where the rubber hits the ground, which is when we started working in many of the large public maternities, there was no distinct separation of initial triage, labor, delivery, postpartum care. It was, and so one of the first things we did was just to map out what the processes of care were and to separate care into phases in which specific standards, standards-based processes could be implemented. A final example, and there are many others, are the difficulty of just having the oxytocin available, especially if you're trying to integrate with newborn care. As I think our colleague from Guatemala mentioned, in many of our facilities, there was no, power was constantly out. There were no working refrigerators much of the time, and we just used actually coolers that came up from northern Nigeria, and providers would prepare, when the woman started pushing, a pre-filled syringe of oxytocin to be right at the bedside. So very simple things like this. And then having teams come together, which was part of our approach, come together on a regular basis, both at the regional and national level and district level, to share their changes and to also track collective results, which was very empowering and motivating because people felt part of a larger process. And in addition to sites using the data for continuous quality improvement to overcome obstacles, district managers, regional managers, and national managers were regularly also using the data to support the site-specific teams. I'd like to just end with a slide on the question of sustainability. Obviously, this is a huge challenge for all of us. We are now conducting operations research in Niger to try to assess what the sustainability of our collaborative work has been. And this bar graph shows results for compliance with Amstell newborn and preeclampsia standards gathered through a combination of direct observation of births and some simulated births, as well as record chart audits during and 6 months after the end of the collaborative. And we're encouraged by these preliminary results. We will continue to collect data in 6 months and again at 12 months. And we hope and we would like to make the case that when you integrate record keeping and data collection and ongoing analysis into routine care at the local level, at the district level, at the regional and national level, it may in fact serve as a strategy to help sustain the intervention. Thank you very much.
Thank you, Kathleen. And I invite now the presenters to approach the microphone for any questions you may have now, and we can start there.
Thank you all. One comment / question, if any of you are doing this. I just came back from visiting some of our sites in Nigeria, and when I looked at the logbook, Amstell was very nicely checked off routinely. You know, use of uterotonic, controlled contraction, uterine massage. But then one of the other steps that we did is a checklist where we actually observed deliveries. And uterotonics are pretty routinely used. I'd say we've been successful on that. Controlled cord traction, yes, but not necessarily correctly. And uterine massage, not so much. So are you integrating in actual observation of the deliveries to be able to validate it to what you find? And my second question before you answer that is, when you estimated the number of PPH cases prevented, how did you do that?
So your question is very much appreciated, getting at the difference between what's being checked off on a chart and what actual practice is. And we have, as part of the collaborative model that I was sharing with you, we do monthly to bi-monthly coaching of individual sites depending on the resources available. And as part of that coaching, the supervision, sometimes more in some countries more than others, has included direct observation, and often what we've also used is simulations. Because of the challenge of, when you go to visit a site, you may, especially a small peripheral maternity, you may or may not have a childbirth to observe. In the larger sites, it's much easier. And as part of our training, we do certificates of competence. Our training is very competency-based. And the same individuals typically who do the training are doing the ongoing supervision. So there's a very strong emphasis on ongoing monitoring. We're also now trying to look at strategies such as peer-to-peer observation with structured checklists as a potentially more sustainable strategy, because, of course, as we go to scale, the challenge is how do you really sustain this? And then your second question, I think, was for my colleague.
I have the luxury, actually, of having our team here, so maybe Soumya and Martha can answer that.
So I'm Soumya Ramarao, and let me answer part A of your question, and my colleague here, Martha, will answer part B. It's really a team effort. So the data that was presented here is the HMIS data, the regular data that's normally captured at the facility level. So in addition to this, we do want to know what is really happening. And so we've done a baseline a few months after the intervention was put into place, where we've got information on, by observations of deliveries as they occurred on all the three components of Amstell. And we are planning to do another follow-up with observations, as well as talking to clients to the extent that they are able to report about what happened to them during delivery. So that way we'll be able to have a better sense of what the validity of the information that we are presenting. You know how it is in most health systems. MIS data is MIS data with all its patchiness. So we do need to do other types of evaluation.
And just the estimation, really that's just for demonstration purposes, but if there's no intervention at all, probably 8 to 10% incidence of postpartum hemorrhage. So 8 or 10 women out of 100 will have a postpartum hemorrhage. We know from the trials that the relative risk of postpartum hemorrhage is reduced to 0.38, so 2/3 of cases, potential cases of postpartum hemorrhage, are averted with the practice of Amstell. So really just took total births, 8 to 10% of those would have a postpartum hemorrhage, 2/3 of those are averted. Just an estimate.
Okay, thank you. Perhaps one more question we can take? Anything from the audience? Yep, back there.
I just have one question. Maybe it wasn't a factor. I'm curious about the programs. If you, in your attempt to integrate the monitoring and evaluation, if you ever found that you wanted to use the partogram to integrate the Amstell, but then you realized they weren't using the partogram or didn't know how to use it, and what that does to your progress, and you can't really move forward without doing that first. I'm just curious how that was managed, particularly in rural sites with lower level providers.
Who wants to take it?
Well, I can speak specifically to Niger, where I was living when this program started. And we actually, during the first 4 months of this work, there was an almost countrywide level stock out of partograms. So this was a huge challenge for us. And we basically made do temporarily with just stamps on sheets of paper. However, in general, our experience has been that when the partograms are there, we place a tremendous amount of emphasis on supporting use of the partogram as part of our maternal newborn work. It's an essential tool. And so we really try to, as much as possible, avoid duplication of parallel records. We found that is, really non-sustainable. And so to the extent possible, we work to integrate all of our monitoring work into established national records, just as Niamh was saying, either through additional columns and registers or additional stamps, while we advocate it at country level for revisions and updates.
Okay. Well, all right, so this brings to a close our morning sessions. Thanks for listening while building an appetite. And now we will be breaking for lunch. And
we're gonna. If everyone could come back at 5 to 1, because we're gonna start the next session at 1. That would be fantastic. So there's gonna be lunch where you all had breakfast, and then we'll meet back here at 5 to 1. Thank you.